Hi, my name is Kaiwei. I'm a Year 4 MD PhD student from Duke NUS. And for the past 2 weeks, I had the privilege of attending an elective hosted by SGH Radiological ACP. And I must say, after going for the elective, I am more and more interested in radiology itself. Before going in any further, let me first explain why I want to do this elective. So initially, my love for radiology started during second year of medical school. So when I first look at scans during the different rotation, I realized I enjoy that process of trying to figure out what's going on in the scan. And I then take a PhD in the field of nuclear medicine. Before deciding going full on into radiology, I decided to have a perspective by doing a radiology elective. This elective was really what I needed because this elective gave me unprecedented access into the inner workings of the radiology. I was able to observe, check, and understand the workflow of radiographers, ultrasonographers, to interventional radiologists and nuclear medicine, above having the opportunity to chat more in depth with the diagnostic radiologists. As adapted from the wise words from a certain radiologist, there is always something in radiology for everyone, and I will now share some interesting snippets that I encountered with each of these experts. Though I have seen many scans before, this was the first time that I get to see how scans were performed. From the healthcare assistants admitting patients for the scans, to nurses placing an IV plug and inserting Foley catheters, to porters preparing the machines, to radiographers securing the patient for the scan, insufflating the patient and pressing a series of buttons to initiate the complex scan protocol. The entire team needs to function like a well-oiled machine to perform a scan. During this shadowing, I learned a few things that was a great feedback for our work in the future. As I speak to one radiographer, I was informed that there was once a patient that was unaware about the need for a Foley placement and insufflation needed for the scan. And because of that, it resulted in an unpleasant encounter in the CT room. As clinician to be, it's thus crucial to ensure that our patients are clear regarding the procedures they are consenting for. My time with the ultrasonographer observing thyroid, renal, groin, scrotum and DVD scan has also reinforced my anatomy knowledge. I managed to appreciate indirect hernia in real life with Valsalva movement pushing the omental fat into the deep inguinal ring that is lateral to the inferior gastric artery. My time in the reading room with the consultants of the various systems has also taught me a lot. Firstly, I need to brush out my anatomy to describe what I see better. Secondly, I learned the appropriate scans and protocol for the appropriate work. For instance, I saw worked up for renal calculi using plain X-ray KUB, ultrasound 2 CT KUB. I even learned about how dual energy CT can help determine the composition of the renal/ureteric stones, which can affect the decision for lithotripsy. I also saw the value of MRI, not just for diagnosis, but also to evaluate the success of arthroscopic keyhole repair for medial meniscus tear, and also to evaluate for pedicle screw loosening to preempt a potential prosthetic failure. One of the other highlights of this radiology posting will be the 2 days that I managed to follow an IR consultant, Dr. Alfred Tan. I managed to follow him for 2 days to do all the various interventional radiology procedures, and he even graciously allowed me to perform lumbar puncture under the guidance of both ultrasound and also X-ray. He also allowed me to see various biopsy, renal biopsy, lung biopsy, and I even have a privilege to join him into one of a very difficult case of CVC line insertion. So one thing I learned about interventional radiology is their life is pretty dynamic. I mean, they get to do hands-on procedures, they get to see patients in clinics, and they even need to read radiology scans as well. So I learned that their life is dynamic and also to a certain extent tiring. Lastly, my time in nuclear medicine also reinforced my interest in this specialty. Though many CT MRI protocols for the various applications used for anatomical scans were already cool enough, nuclear medicine with the various PET, radiopharmaceutical also allowed me to visualize the human physiology above just the anatomical structures. I mean, in theory, you can visualize whatever your radiopharmaceutical targets. So sky's the limit, and therefore there's a lot of research potential which I am absolutely interested in. Some good examples are PSMA and SSTR2 targeting radiopharmaceuticals to image prostate cancer and neuroendocrine tumors. With a switch from diagnostic to therapeutic radioisotopes, these radiopharmaceuticals can also be used as treatment modalities, earning themselves the name of theranostic. I myself had the privilege of creating a radiopharmaceutical in the course of my PhD to image the target programmed death ligand 1 PD-L1 protein under the tutelage of Assistant Prof. Anne-Marie Chakru from Duke NUS. Besides cancer, nuclear medicine also transfers multiple fields like infectious disease, orthopedics, cardiology, and many others, as they also perform treatment for patients such as radioiodine treatment and the peptide receptor radionuclide therapy (PRRT). And for that matter, they also do see patients in the clinic and manages patients at wardside. I also love it that whenever doctors from different specialty ran out of ideas or need to do interesting scans to identify very rare things, they look for the nuclear medicine doctors. For instance, if let's say there's an occult fever or pyrexia of unknown origin, a nuke med doctor can image the white blood cells specifically to locate a potential abscess. Whatever I'm telling you here is just the tip of the iceberg when it comes to the type of scans that nuclear medicine doctors can do. And currently, this is based on the currently available radioactive pharmaceuticals that can be used for diagnosis and treatment. And I mentioned that this repertoire is increasing. So for that reason, I'm really excited of this space and I would love to contribute more to the growth of this space. I'd like to take this time to thank Dr. Dorinda, who has planned and organized this elective program, and we have truly benefited from it. I also like to take this time to thank the various doctors that have joined in the reading room, the name shown here, and also the doctors they have taught us during our quiz and tutorial sessions. Special thanks to Dr. Alfred Tan, who I have the privilege to observe and follow for 2 days consecutively, and I'm very grateful that he gave me opportunities to try out some procedures as well. I hope I've either made you interested in radiology or have mentioned something you can resonate with in my sharing. If you like what I have shared here and want to watch more or link up with me, please like, share and subscribe to my channel at MD PhD Live. I hope you have a pleasant day, and this is MD PhD Live signing off.